Hello, this is Dr. Lawrence Bureau. Welcome to my talk on the approach to geriatric history. Today we'll be talking about how to deal with polypharmacy in the geriatric population. By the end of this talk, you'll appreciate that geriatric patients typically have multiple chronic diseases. Appreciate geriatric patients frequently are multiple medications. Appreciate that underdosing, overdosing, or medication errors frequently lead to symptoms in the geriatric population. And lastly, integrate this knowledge in order to take an efficient history. The overall population of our patients is slowly aging. More and more patients are over the age of 65 and have multiple medical conditions. Therefore, it is imperative that we know how to work and serve an older population for our future practice. The geriatric population differs from a younger population for multiple reasons. First, they're medically complex. This means they will often have multiple medical conditions, including multiple surgeries, multiple hospitalizations. They will often be followed by multiple specialists. Furthermore, their chief complaints will often be vague. They'll frequently come to the office complaining of weakness, dizziness, or fatigue. Often, their dizziness will not easily break down into the paradigm, which we usually talk about, such as vertigo and presyncope. Making it slightly more difficult to figure out the cause of their problem. Nextly, there are often poor historians. While many of them are able to give you an excellent history, quite often their histories do not follow a typical OPQRST format. Furthermore, the onset to their illnesses are often vague. Their conditions are frequently chronic, lasting a very long time, with an exact start date unknown. Furthermore, the differential diagnosis for these patients is often very broad, making it difficult to rule in and rule out different entities. To help give you an approach of how to deal with this complexity, I'd like you to go through the following exercise. First, I'd like you to create a list of major systems, such as cardiac, neuro, etc. You get the idea. Next, within each system, I'd like you to list all the major conditions, such as coronary artery disease, hypertension, and the list goes on. Next, within each of these categories, I'd like you to think of the major medications that are used to treat these conditions. Things like ACE inhibitors, diuretics, and whatnot. And lastly, I'd like you to think of what would happen if a patient with these conditions either took too much medications or took too little medications, and what type of symptoms the patients might have. Now, to ensure you're actually doing this exercise, I'm going to take a little bit of a break and draw silly pictures. So, here's my answer to the exercise, and it's generally there's no one single right answer, but it's generally the list of major conditions which I think of. So, in the center, we have our patient, and the geriatric patients generally have multiple conditions. Cardiac conditions are quite common, with hypertension, coronary artery disease, congestive heart failure, and AFib. In terms of respiratory conditions, I have lots of patients with COPD. In terms of neuro, I have dementia, Parkinson's, and often there's various neurogenic pain symptoms. MSK issues are quite common. Patients will often have osteoarthritis, or back pain, or other muscular types of pain. In terms of genital urinary issues, women and men have different things. Women will generally have some type of incontinence, and men will frequently have a large prostate, or BPH. Psychiatric conditions are quite common in the elderly as well. Typically there's depression, anxiety, and often sleep challenges are quite common as well. And lastly, I'll put down endocrine issues. Hypothyroidism is remarkably common, along with diabetes. I hope this has sort of given you a flavor of the conditions that are quite common in the geriatric population. Now I'd like to take a closer look at these conditions and look at the effect that these medications can have on a patient, if they're overdosing or underdosing on their prescriptions. Firstly, let's look at cardiac conditions. Cardiac conditions are very common in the geriatric population. Many patients have hypertension, coronary artery disease, congestive heart failure, and atrial fibrillation. There are many medications used to treat these diseases, including furosemide, beta blockers, calcium channel blockers, ACE inhibitors, and diuretics. Patients who overuse these medications will frequently have hypotension and feelings of weakness. Furthermore, if their blood pressure becomes low enough, they'll often have falls. Patients who have atrial fibrillation will be on beta blockers to control their heart rate. If they are on insufficient beta blockers, they'll be tachycardic with an elevated heart rate. And if they overdose on their beta blockers, they'll have a low heart rate or be bradycardic. Both of this can give you falls. Patients with atrial fibrillation will also be on blood thinners to prevent stroke. Most commonly, they'll be on Coumadin or the new oral anticoagulant agents. Patients on these agents with falls may have subdurals. They have progressive weakness and neurological symptoms. That's certainly something you should worry about. Respiratory conditions in the elderly are also quite common, with the most common condition in my practice being COPD. You'd be surprised about the number of patients whose COPD is poorly controlled and wind up taking their short-acting beta agonists such as salbutamol or Ventolin multiple times a day. I've talked to more than one patient who takes 15 to 20 inhalations per day. The side effect of this medication is tachycardia or elevated heart rate, and this too can lead to falls. Next we'll move on to chronic neurological diseases. Dementia is very common in the elderly. Many of these patients are on cholinesterase inhibitors, such as donepezil. This medication can have side effects even if taken properly, causing weight loss, anorexia, and increased vagal tone. Increased vagal tone can cause presyncopal episodes and ultimately will lead to falls. Parkinson's is also quite common in the elderly, and many of these patients will be on carbidopa and levodopa. Patients who are not taking their medications properly and are underdosing may have dyskinesias, which can lead to falls, and patients who are overdosing may have orthostatic hypotension, which can also lead to falls. Neurologic causes of pain are also quite common in the elderly, and many of these patients will be on amitriptyline or tricyclic acids, amongst other medications. These medications will frequently have anticholinergic side effects. And if you don't remember what these are, remember the little poem, Blind as a Bat, for the eye problems, Mad as a Hatter for the confusion it can cause, red as a beet for the flushing, and dry as a bone for the urinary retention. These two can cause falls. I'm not sure if you've noticed the theme here. Next, we'll move on to musculoskeletal issues that the elderly frequently have. Osteoarthritis and back pain are extremely common, amongst other conditions. These are frequently treated with acetaminophen, NSAIDs, and far too often, opioids. Many patients are on things like Percocets and Tylenol number 3s, possibly too many. Opioid medications can cause drowsiness and decreased levels of consciousness, which can lead to falls in the elderly. Genital urinary issues are also quite common. In men, you have benign prostatic hyperplasia, which is often treated with alpha blockers such as tamsulosin. These medications not only have effect on the prostate, but they also have effect on the blood pressure and can cause orthostatic hypotension, which can also lead to falls. Women will frequently have either urge incontinence or stress incontinence. Stress incontinence is frequently treated with anticholinergics such as stolterdinine. With too high of a dose of these medications, you could have anticholinergic side effects, which was just discussed on the previous slide, and it can cause falls as well. Psychiatric conditions in the elderly are quite common. Many patients will have depression and anxiety, often treated with SSRIs, SNRIs. When these medications are overdosed, they can cause multiple side effects, including, but not limited to, fatigue, dizziness, and drowsiness. All these types of symptoms can lead to falls in the elderly. Sleeping issues are also quite common in the elderly, and unfortunately, benzodiazepines are prescribed far too often. These medications, such as Ativan, stay in the system much longer in the older patient and ultimately can cause fatigue and tiredness. Both of these can ultimately lead to falls. Lastly, I'd like to look at endocrine conditions in the elderly. Hypothyroidism is remarkably common, with many patients being on thyroxine for hormone replacement. If this medication is underdosed or not taken, the patients will frequently have the symptoms of hypothyroidism, including cold intolerance, fatigue, weakness. Patients who overdose under thyroid medications will frequently have symptoms of hyperthyroidism, and I'll let you figure those out on your own, so I'm sure you're quite familiar with them. Ultimately, all these symptoms can lead to falls. The other common endocrine condition that the elderly have is diabetes, and there's many medications that can be used to treat diabetes. The classes include ubiquinized sulfonylureas, DTP4 inhibitors, and insulin. Patients who overuse their glycemic agents will have hypoglycemia. Patients who underuse their medications will have hyperglycemia. And I'm reasonably certain you know where I'm heading with this, as this too could lead to falls. So when I have an elderly patient coming to my office, I'll ask them to bring all their medications with them. They usually come with a big bag full of pills. I usually empty out the bag and look at each of the pill bottles individually. On each pill bottle, I'll look at the date of the prescription. This will tell me if the pill bottle has been sitting on their counter for the last 2 years and not being touched. I'll look at the number of pills left in the bottle, and this will give me an idea whether the patient is actually using the prescription or not. I'll look at the prescribing physician name on the pill bottle. This will let me know whether the patient is visiting multiple physicians, which physicians are visiting, and what specialists they're seeing as well. I'll ask the patient how they're taking each pill individually. This will allow me to know whether they're taking it correctly. Patients often will confuse the number of times the pill is supposed to be taken, or the timing of the day, or some patients will take a pill on a PRN basis that's supposed to be taken once or twice a day, every day. I'll look at the pill to see if there's any duplicate prescriptions. And this is often quite easy to happen because pills come under different names. And if a patient switches pharmacies, they'll wind up with 2 pill bottles with 2 different names on it, but the same medication. For example, they might have one pill bottle that says Altase and another pill bottle that says Ramipril. Both of these are the same medication, but one's under a generic name and one's under a trade name. And it's very easy for a patient to be doubling up on a medication accidentally. Next, I'll look at their medications and compare them to my medication list that I have in my records to see if they're missing any medication that they're supposed to be taking. And lastly, I'll see if they're still taking any discontinued medications. Often, communication errors will cause patients to continue taking medications, even though you may have asked them to stop. Usually, if something is wrong, it'll be pretty obvious. You'll be able to catch errors quite quickly just by doing a medication reconciliation. When a geriatric patient comes to my clinic, this is the approach I generally use. First, I ask for the chief complaint. Next, I move to the identifying data. And next, I move on to the medication history. And I use the approach that we discussed on the previous slide. After I'm finished looking at all the medications, I get a full past medical history. And for every single medication, I make sure I have an explanation for past medical history. And by the time you get to this point, even before you moved on to the HPI and the rest of the patient's story, often the reason for their chief complaint will be quite obvious. But not always. But hopefully by taking a full and detailed medical history and medication history, getting the rest of the story is going to be much easier. Lastly, I like to say that over the years I have picked up a particular set of skills. So, if one day one of your patients comes to your office with a big bag of pills, if you not look at each and every one of these bottles, I promise you, I will know and I will find you.